Good morning. This is an updated narrative review of the impact healthcare disparities have on patients with lung cancer. In particular, we will focus on racial and ethnic disparities in the context of the United States. Lung cancer is the second most common cancer in the US and the leading cause of cancer mortality. Currently, major racial and ethnic disparities exist in lung cancer. Among African American and Black populations, there are pointed differences in the screening, diagnosis, management, and survival of lung cancer patients as compared to other racial and ethnic groups. We want to reiterate that these categories are socially constructed and relevant for the US population based on their use within national registries, health systems, and the census. Among those diagnosed, African American and Black men have both the highest incidence rate and the highest age-adjusted mortality rate, shown here at 75.7% per 100,000 people. In recent years, differences in incidence have narrowed. However, Black patients with lung cancer are often diagnosed at a younger age and continue to present with more advanced disease as compared with their white counterparts. Among the many risk factors, the two most important are smoking and increased age. Smoking shows disproportionate excess risk in African American and Black communities. Specifically, in these populations, they have comparable rates of tobacco use to other demographics at 20.2% per 100,000 people. However, they still have the highest rates of age-adjusted lung cancer mortality. Currently, screening programs are used to address these risk factors. Lung cancer screening usually involves low-dose computed tomography. The old 2013 guidelines included patients aged 55 to 80 years with a 30-year PAC history. The recent 2021 update has made lung cancer screening guidelines more inclusive to ensure that younger patients with lower levels of smoking exposure can be screened. They have been brought in to now include patients 50 years and older with a 20-year PAC history. There are currently a number of ongoing issues with the new implementation of lung cancer screening changes. First, the inconsistent documentation of patients' smoking history may negate the positive intentions of more inclusive screening guidelines. Additionally, the geographic location of screening centers creates a large variation in access to regular screening between rural and urban populations. Financial elements also come into play, as some uninsured patients do not have the ability to access annual visits and may have difficulty with reimbursement after imaging. Racial and ethnic disparities also exist in screening. The 2013 USPSTE guidelines missed many high-risk Black smokers due to younger age, fewer PAC years, and shorter quit times in this population. Black patients have lower screening rates compared to their white counterparts and make up 8.4% less of the screened population as white patients. New updates in screening guidelines hope to reduce this disparity. Now, when it comes to lung cancer management, patients can be treated with surgery, radiation, chemotherapy, or a combination of treatments. This figure shows the adjusted relative odds of non-surgical treatments compared to the reference of surgery only in Black versus white lung cancer patients. Black patients with stage 1 non-small cell lung cancer are less likely to be offered and receive surgery, and more likely to receive radiation therapy, chemotherapy, and combined treatments. One study found that Black patients have a 55% lower odds of undergoing surgical resection of their lung cancer. Additionally, a recent SARE Medicare registry study also found that 18% of Black patients did not receive surgery, as compared to only 11% of white patients. Now, once Black patients do decide to undergo surgery, they are also more likely to have a sublobar resection rather than a lobectomy. In stage 1A non-small cell lung cancer patients, sublobar resections, specifically wedge resections, have been associated with a significantly lower probability of survival due to lower rates of nodal exam and less number of total nodes examined. That is, even when adjusted for the extent of surgery, Black patients have a lower likelihood of having 15 or more nodes sampled. Now, in the past 15 years, there has been an increase in the amount of patients refusing physician-recommended surgery and instead electing for non-surgical treatment modalities. This population also experiences a longer median time between diagnosis and treatment. Furthermore, by abstaining from surgery, many Black patients are less likely to receive stage-appropriate treatment. Disparities also exist in survival and patient outcomes. The 2-year cancer-specific survival between white and Black patients is significantly different, with Black patients surviving an average of 80 months and white patients surviving an average of 107 months. Long-term survival differences also arise in the unadjusted 5-year survival rates, as they are significantly lower for Black patients with stage 1 lung cancer and overall. These survival rate differences are in part accounted for by lower rates of surgical treatment in African American and Black patients. Now, in order to mitigate these disparities, healthcare systems must encourage equity and increase access to screening and treatment options. This can be achieved through outreach and awareness programs that explain the purpose and protocol of screening. Additionally, there needs to be an emphasis on provider-based interventions for point-of-care reform. Ultimately, a community-engaged approach through access, understanding, appraisal, and application is required to benefit target populations and help develop appropriate health communication materials for the impacted demographics. Another interventional model is the ACCURE model, a system that utilizes the PSAB Undoing Racism framework as a conceptual model for medical care. This intervention trial consists of 4 main components: a real-time registry warning system, a nurse navigator, feedback to clinical teams, and health equity training sessions. Ultimately, the ACCURE model strives for enhanced transparency, accountability, and quality improvement. In a recent study, these interventional strategies have been found to eliminate the Black-white disparity in lung cancer treatment, while control groups continue to observe a marked difference in treatment completion. Ultimately, non-white groups, specifically African American and Black patients, are experiencing disparities in lung cancer screening, diagnosis, management, and survival. Future directions need to address these disparities through community-engaged approaches and patient-centered care, where providers understand the barriers patients experience. As the existence of disparities in lung cancer continue to increase with time, there's a pertinent need for new investigations that attempt to mitigate disparities in care at the intersection of race, socioeconomic status, and lung cancer. Thank you for your time. And thank you, CTSNet, for the opportunity to present on this topic.